Welcome to the Totally Adequate podcast, produced by Quest Analytics. Here, we dive into the latest news, policies, and innovations in healthcare provider network management with industry leaders who are shaping the future of care. Our mission? To elevate community health across the nation through superior provider networks.
Hi, I'm April Beane, and welcome to the Totally Adequate podcast. I'm really glad you're here today because we're going to be joining a previously recorded webinar that I had the privilege of interviewing Joshua Abraham from Common Spirit, as well as our very own Bob Tavernier. We were talking about how insights transform network performance, in particularly through affiliation insights. You know, we had a really big discussion about how organizations today really are information rich, but data poor, meaning we have all this data that we bring in. We're just not leveraging it in ways that help us with our network design, with the complexities of our network strategy, and really overall improving member access by having a better understanding of that roll-up of contract entities and affiliation. So without further ado, I want to join that webinar and we'll break it down a little bit when we come out of it. I am very excited to be joined today for our webinar with Bob and Josh. They bring two very different perspectives to what we're going to be talking about today. We've had an opportunity over the course of 2025 to talk about this topic at several different conferences with our clients and throughout the industry. And we want to bring some of those insights and that conversation to you here today. So let's get started. One of the things that we have had resonate with us throughout the conversations we've had throughout the year is that as an industry as a whole, we tend to be data-rich, information poor. And what do I mean by that? We, as health plan executives, as analysts, folks that are working in provider network management, we have a lot of data coming at us all the time. The problem is we're not always leveraging it collectively as we should. So sometimes it's siloed. Sometimes we're only using it for one perspective, not across the enterprise. And that creates issues, right? And so we're going to explore that a little bit here today. And as we do that, I want to give an example of the past. So Josh and Bob, bear with me here for a second and follow along. I'm sure a bunch of people are laughing right now looking at this. But if you remember back in the day, this is how we kept patient member data. This is where it was all kept in these lovely files. And it took us almost 2 decades as an industry to collectively come together in an effort to make this easier, make it simpler. And so where we are today with this is our portals, right? Now we can very easily go on to our phones. We have EMR records. We can share our medical records across health systems, across providers. We can look at it ourselves. And, that has changed the industry in a very dramatic way. We're looking at affiliations and contract entities here today as kind of a similar problem that as an industry, we are challenging ourselves as a whole to try and make improvements in this area and to fix this. And it's kind of that data-rich, information poor situation all over again. And in particular, when we're looking at how we build our networks or the life cycle of our networks, which we're going to talk about today, Josh, Bob, you know this, from a health system perspective, from a payer perspective, we just don't build our networks based on single MPIs and TINs, right? Like that's impossible. A prime example, we looked at Atlanta, and we have a payer who is trying to fill their Atlanta network. And in order to do that for compliance and also to meet the needs of their members, they would have had a contract with 2,800. Yes, let me say that again, 2,800 providers, MPIs, right, in order to fill that. That's astronomical if you're thinking about having to do 2,800 contracts, right? Like that's crazy. But if you start to ladder those up and you start to look at the affiliations and the contract entities that they're associated with, like we did in this example in Atlanta, and you start to see what that ladder up process, now you're talking about only having to contract with 400 entities. That seems a lot more doable. I see you nodding, Josh, and we're going to talk to that in just a minute. But you went from 2,800 individual MPIs, TINs, providers, that you have to contract with, to 400 entities, because you have a better understanding of how they ladder up and which of those contract entities or affiliations you could contract with to get all of the different providers and specialties that you need to be compliant and to meet your members' needs. So I want to dive into this a little bit more, but I want to level set on what do we mean by the complexity of that ladder up. So Bob, I'm going to let you dive into that. We've got two examples here on the slide that I'd like you to kind of walk through. Why is this so complex, and how should we be looking at how these ladder up?
Absolutely, April. It is a complex world, especially when you think about NPI 1s, NPI 2s, TINs, contract entities, hospital systems, inpatient hospitals, outpatient facilities. What does all that mean? So in this first example, we look at that practitioner as that NPI 1. They have that professional affiliation with a provider group, or an NPI 2. Payer organizations refer to it as a TIN. They have that institutional relationship with a health system. In this case, the practitioner also has an institutional affiliation with a facility that's part of that health system. So in this case, the payer would actually need one contract with the health system of which the facility is a part of. What's unique is when you think about that second example on the right, the practitioner is part of an independent physician group. They have their own contract entity. They go from a rendering NPI to a billing NPI with that contract entity, but yet they have admitting privileges to an institutional affiliation or that health system and facilities. So in this case, a payer organization would not only need to contract with that individual provider group, but also with that health system in order to ensure that that member has complete end-to-end in-network access based on their experience.
Fantastic. Bob, thanks for walking through this, because I think that level sets us as we go into the rest of the conversation for today. And ultimately, the goal is to be data rich and information richer, right? Like, we want to be able to leverage the data that we have available to us in order to make more strategic decisions. And so as we start to think about those strategic decisions, Bob, can you let's start with you, since you were already talking. What would you say is the biggest challenge that you see in network design today?
It's a great question, April. And when you think about network design, it is complex. Understanding where you're at from a corporate strategy, from a market strategy, from a line of business strategy, from a geography strategy, and where are you at? What are you trying to solve for? What problems are you trying to solve? You had mentioned the example earlier of going and having a contract with 2,800 NPIs versus contracting with a much smaller subset. So it truly thinks about scaling, operational, and the ability to be very efficient with your operational model by understanding the complexities of the data, really being able to dive into the data using a trusted source, understanding where does that provider have relationships with which contract entities, with which hospital systems, with which facilities, and being able to move very quickly on not only being able to solve for network adequacy gaps, but truly thinking about what type of a network does a payer organization, for example, want to build. What is the product and benefit design? What position do they want to be in the market? Whether they have a high cost network, a narrow network, and ultimately, how do they really think about affiliations as within their toolkit to truly help with that network design? At the end of the day, it's about the member. So when you think about that, you really want to ensure that you understand what are the patterns of care? Where are these members going? What's the type of care that they need? When you're looking across your spectrum of provider type specialties, ensuring that you really have a sound network design strategy that's speaking to not only the clinical aspects of having a strong tie-in between your network, the clinical relationships between the contract entities, the hospitals, the hospital systems, the outpatient facilities, and truly understanding what those dots look like, and that you can connect those dots so that, again, back to that member example, if they're working with a provider or they're working with a unique specialist, that they have a true in-network experience across the board, and that member satisfaction remains high.
So, Bob, I know a lot of today you're going to be coming from that payer perspective. You have not only that experience in your past, but also in your role at Quest Analytics. Josh, we haven't heard from you yet. I want to bring you into the discussion now. You're coming at this from a different perspective as you work with Common Spirit. Maybe set that up for us a little bit as you tell us what's most important or the biggest challenge for you for network design.
Yeah, thanks, April and Bob. Very well said. As April mentioned, with Common Spirit, we have a unique perspective as a payvider. So we're a model that focuses both on kind of seamless patient experience and by linking coverage and care together. So it allows us to have both claims and clinical data, and that allows us to a more comprehensive view of unique patient needs across diverse populations, and that allows us to kind of tailor our network to our different population needs. And so, kind of, April, to your point, perspective, right? Some of the biggest challenges that I see, and we see from a payvider perspective, is, you mentioned it very, very early on, is just fragmented or inaccurate provider data, right? There's numerous sources across a lot of publicly available resources, and it's kind of difficult to paint a picture on a specific provider or provider group when you have kind of different pieces of the puzzle that don't necessarily line up to create the same image, right? You may have claims data to look at cost and quality to design your network. However, those claims data may be from 2022, 2021. They may be only from a Medicare line of business, so you're completely in the dark for, from the commercial side. You also have challenges with credentialing if providers are not on some sort of electronic sort of updating resource. So location confidence becomes a big issue. And mainly, I think one of the biggest challenges in network design is not accounting for social factors. To offer a network that is kind of reflective of real care, of real world care. And that is a huge, huge challenge, because meeting adequacy and access on paper is useless if you don't integrate, some sort of population health and social determinants of health, like race, language, income. All of these factors are really, really important in network design. And as Bob said, it's not just going out and contracting with, a single entity. You have to take into account the entire complex system from both the provider side to the facility side, and to create the entire picture together.
And what I'm hearing you also say is it needs to reflect, a real world care delivery system, right? So not just where the numbers are, but what's really happening. Like, where are your members? What are their needs? How do you maintain and improve their satisfaction and making sure they're getting to the right provider at the right time at the right place, right? So as we continue our discussion, I want to walk through something real quick, because this is going to be important as we move on. Is talking about the network life cycle. Now, this says Medicaid, but obviously we follow this cycle regardless of whether we're talking Medicare or Medicaid line of business, right? There's a process that we go through as we build out our networks, and a lot of that starts in that strategy phase. So when you're evaluating new market signals, looking at your financial feasibility and strategy of your organization, and determining that data role, right? We're talking about that data role right now, which is highly important. And then when you move into that build phase, you got to talk about foundational relationships, and in Medicaid really specifically, but across all lines of business, sometimes there's that foundational health system that you have to contract with in order to even be viable within a market if you're going into it, and being able to identify that. Then you start your recruiting and your contracting, and then ensuring compliance, which is foundational. You got to do that as well. And then optimize phase, right? You got to optimize for performance. You got to get those metrics that matter and not just have them, right, siloed within your organization, but actually leveraging them to make strategic decisions. And then all of this is an effort to sustain excellence and member satisfaction. So as we start to look at this network life cycle, Josh, I'm going to start with you. Talk to me about how art of affiliation intelligence, so what we're talking about, this ladder up here today, can help you build smarter networks throughout this entire life cycle. Is it more important in one phase than another, or is it something that you really need to leverage, regardless of where your particular network is at?
No, fantastic question. And to start off, affiliation intelligence is something that you'll need in the entire phase, from start to finish of a network design. So you're going to use it from building your network, and you're also going to use it, post building to kind of align the health of your network. So it really brings a lot of transparency between the relationships of individual providers, groups, hospitals, and specialists. It really allows to identify, the main thing is key referral patterns, right? To create networks that are based on where patients are most likely to seek care and where true provider alignment lies. We all know that we have, certain providers that are either employed by us or independents that refer to their golf buddies, their college buddies, out of just that personal relationship. But we would never know that until you had affiliation kind of data, right? And so that kind of brings a magnifying glass into those true provider alignments. And so you can find out that your quote unquote in-network providers can be aligned with your out-of-network competitors, right? It's something that happens all across our organizations. And vice versa, you can find out that some of your out-of-network providers can be surprisingly aligned with your own health system or your group. In that case, if you never had that data, you would never consider going after them to potentially contract. And that is an indication of contracting. So it kind of gives us the reality of our current network and whether or not it is going to function the way we intend or the way that we designed it to be. And additionally, it can play a huge role in contracting. When you identify providers that are part of larger health systems or have ties to larger health systems, you can kind of surmise that they may have above average contracts with the payers, right? Therefore, if you were interested in contracting with that specific provider, negotiations with kind of a straight fee-for-service reimbursement tactic may not be as fruitful, especially if your rates are subpar compared to what they're getting, elsewhere or what they currently have. So in those instances, having the affiliation data is important because those negotiations would be better with independent providers who are more keen to fee-for-service, right? Instead of leveraging with the providers that are part of the larger health systems, you would leverage more incentivized contracting through kind of ACO programs, capitation models, and those types of tactics can be the key to keep providers enticed for you to contract and have them join your network.
Josh, I like what you're what you're talking about when it comes to patterns of care as well as contract negotiations. What I'd like to add is the site of care as well. Getting that member to the right level of care at the right time in the right place. Gone are the days of individual physicians truly providing services on their own. Yes, they still exist, but more and more we're seeing that trend of a lot of these independents pulling together, right? They're developing, larger contract groups, larger ACOs, clinical integrated networks, but the ability to be able to save on the efficiency side, lower admin costs, and be able to really help focus on the total cost of care, right, based on the members and patients that they're servicing. I also like to think about the contract negotiation side and back to that site of care. And are they really working with inpatient facilities? Are they working with outpatient facilities? What do they have in place to truly help with that member population, that member concentration based on comorbidities and what given members have within certain geographic areas, and what are they doing to truly create that contract that is truly fulfilling when it comes to working, especially with such as ambulatory surgical centers, right? Those outpatient facilities or other types of outpatient facilities where you can keep them out of that inpatient facility, but truly help to leverage that network to maximize the return for members.
Great point. Fantastic.
Yeah. Yeah, I mean, it really does help you project and predict cost, right? It also helps you add valuable providers to your network. I mean, there's a lot of pieces that having more connected data and being able to see that ladder up allows you to make those strategic choices. I want to move a little bit into the build phase. That ensuring compliance. We all know that that's foundational, right? The performance, affiliation, all this builds on that, but you got to have a compliant network first. So, Bob, when you look at it from a payer perspective, how does Affiliation Insights, knowing this ladder up, help you when you're trying to fill gaps, meet compliance in that build phase of the network lifecycle?
It absolutely helps. Understanding that relationship is really key. From that individual provider up to that contract entity or group level, and knowing that if you're going to contract with that individual provider, you need to understand who else is part of that group and how does that help solve for network adequacy gaps, especially when you're looking across your network, across the provider type specialties. What are the licenses that these providers within this contracting group, what member base can they serve? And how does that ultimately service your ability to close gaps in a very rapid fashion? So we're talking about scalability, we're talking a lot about efficiencies by truly understanding that contracting group entity, but then also the ability to understand the relationships that contract entity has to the larger hospital systems. If you're building a network, you're going to need to be able to identify those core hospital systems that are key, they're foundational, they're pillars as to part of your network, and you need to have a really good support structure in place across your provider type specialties, and that's going to really help you solve for gaps very rapidly.
And Josh, you were talking about making sure you're with hospitals that are in network opposed to out of network, or that aren't referring from one of your competing health systems. Billing risk. Tell me from your perspective what you would add to how it really enhances how you can fill those gaps in a meaningful way.
Yeah, I mean, a lot of this has to start off with kind of what line of service are we trying to, build your network in? Is it a Medicare, Medicaid? Is it a VBC? A lot of that really goes into how you kind of build and fill those gaps. From a provider perspective, right? We both have a responsibility as a payer and as a health system. So from the health system perspective, the Affiliation Insights really kind of shows us who our competition is and whether or not providers in our locale, how many of them are aligned with our competition. And that's important to know as we are looking for providers to fill gaps that are of high cost and quality, right? And so if we were holding kind of a VBC network, for example, you'd want to target providers that have, to Bob's point, privileges at an ASC or specialized outpatient care facilities rather than just a hospital system, right? And kind of Affiliation Insights will help you understand what relationships we have from the providers and the facilities. It can kind of prevent also network challenges that we see, especially. For example, we have a hospital here that is notorious for going out of network every single year with a major provider, right? And so every single year there is member dissatisfaction towards the end of the year when they go out of network until they renegotiate their contract. So having insights into whether or not certain providers are affiliated with that hospital or employed by that hospital can really help prevent those issues from happening, and having a lot of the member dissatisfaction be prevented. And so that's an important thing to note. Also, kind of using internal dashboards to track leakage. We have internal dashboards to track leakage and referral trends, and it can really shine, again, a light as to the efficiency of your current network. The leakage data can be used in conjunction with affiliation insights to determine if certain providers still have an underlying relationship to past ties, even though they may be employed or contracted with you. That really helps kind of paint the picture of whether or not there's an educational opportunity to be served for that provider, or whether or not we need to part ways with a certain provider and fill that gap with another one that is more aligned with us.
Josh, the hospital going out of network, just imagine the impact of that to members, right? I mean, so just really thinking about scenario models and just thinking about what is that experience, right? Not only to the health system, but to the geography, to the members, and really understanding and being able to utilize that affiliation data to understand what's the impact, right? What's the bottom line impact, not only within that hospital system, but within the contract entities that are contracted with that hospital system. And, you mentioned lines of business, are you still adequate? And do you still have an adequate network across your lines of business? And then what's the churn that's happening inside those provider groups? And a lot of times providers are switching, they're supporting multiple lines of business. They decide they're going to no longer support multiple lines and they're going to only support a single line or perhaps a secondary line. So being able to keep up with that clinical view of what lines of business they're supporting, what relationships they have with these contract entities, and then being able to scenario model, right, and plan if there is a disruption, how do you help to game plan, right, against that? And how do you help to utilize that affiliation data to be fast, flexible, adaptive, and be nimble on your feet in order to truly ensure that those members continue to have the care that they need?
Yeah, Bob, that's a great point. And for those of you that are friends, the show fans out here, being in the network design and build phase, you have to always be available to pivot, right? And so having affiliation insights kind of gives you a real life look into current patterns. And again, we said at the beginning, we have to model our networks based off real world care delivery scenarios. We can't just, go off of paper. It's often easy enough just to go and contract with a huge group with 200 providers just to fill a gap. However, to my point, if we have them going out of network every single year with a major payer because they want to renegotiate contracts, or they have specific ties to your competition or to physicians that are not necessarily of high cost and quality, those are things that you would never know about before contracting, and that kind of makes the case of maybe we should look into a different direction as far as contracting and filling those gaps. So to your point, we always have to be able to pivot, but having real life insights to create that picture of when to pivot and what to expect is really important in the building and the strategy phase.
Josh, how long have you been really being able to leverage affiliation insights in your strategy, and how has it contributed to it? So, we were just talking about filling gaps in compliance. We hear a little bit about that, but obviously compliance is foundational, but we're seeing regulatory trends. We're seeing a lot of focus moving into maybe what we call adequacy 2.0, where you're starting to look at data integrity, layering on top of that, quality metrics, cost metrics, performance metrics, and then on top of that, these affiliations. When we talk about being information richer, how important is it to have all those layers, because obviously we got to do gaps first, right? That's compliance. We have to do that. That's the bare minimum. And a lot of times we look at that as, until someone tells me I have to do this, I'm not going to move in that direction. But do you feel like if people aren't moving in that direction, they're behind already? Like, tell us a little bit about your story around building on the foundational metrics and adding in performance and affiliations.
Yeah, like I mentioned in the beginning, I was one of those people that was looking for data everywhere, right? Data is king. Data does not lie. It is based off of actual actionable insights that a provider or a health system has done. So in my previous life, I was looking for cost and quality metrics. I would look at claims data, right? If I was looking at compliance issues, I was looking at data integrity, any sanctions, all that good stuff, what lines of business that they currently service. So again, kind of getting pieces of the puzzle to all fit and to your vision is kind of difficult, right? And so Kind of moving forward, the future of medicine is where you'd have to take in consideration all these points of data. So even though we are data rich again and information poor, we have to start stringing along the data pieces to create a picture of what the future is going to look like and how it impacts today. So cost and quality metrics is going to be a huge key in the future to kind of aligning with affiliation data, to finding out whether a provider is truly going to deliver the care that you expect them to do. Likewise with groups, even though you have a large provider group that you're going to contract with, of 200 providers, maybe only 50 of them are really, really good, right? And the other 150 are just bad apples. So are you really opening up trouble to your network by just doing the bare minimum, right? And so kind of using all these data sets, linking them across, and really trying to put yourself in the patient's shoes from an experience standpoint can really help build a real proper network that will not only stand the test of time, but will have a lot of longevity in the future.
Josh,
Bob, I know you.
I love your perspective on data is king, right? It truly is. I mean, especially when you think about the healthcare industry, and if you're thinking about a data puzzle, taking structured data, unstructured data, trying to stitch it together, industry studies will tell you that's not really that's not the way to go, right? You're going to end up with different methodologies. They don't match one another. Then it gets down to accuracy and can you really trust the data and really use that data as part of your network design and in support of your corporate strategy. So when you're talking about costs and quality, I love what you're talking about. And you're looking at a larger group, and perhaps you've got 50 bad apples out of 200. When you think about total cost of care, medical expense reduction is key, right? That's the P&L. How do you truly help those members get the care that they need, but manage it in a way that's truly effective? So truly looking at claims, being able to pull in quality data, looking at scoring that really thinks about, emergency room, readmissions, days in acute care. On the cost side, what are they charging, right? What are they charging, for individualized services, and how does that compare to other contracting entities that you have contracts with? So being able to truly compare and contrast the data on these provider groups to determine which contracts do you want to truly incentivize. You talked about value-based care and really looking at the prerequisite of who's a good candidate for VBCs. And is the provider truly achieving the outcomes that you're expecting them to achieve, right? To be able to get into a really solid VBC arrangement that's ultimately going to help those members. So being able to use claims intelligence, being able to use data that has a sound methodology, and really being able to truly evaluate, the performance of these contracting groups in support of your overarching network strategy. That's really key in terms of optimizing performance, and it's something that you have to do throughout that life cycle, right? Not only from the build phase, but continuous. Just to continue to really focus in on optimizing care and helping to manage your network overall.
And Bob, this is so true because the challenges you're going to face in combining all these really happens in the rural areas and the expansion areas where you have a limited provider supply, and members really don't have a choice to go anywhere, right? And so kind of data integrity is key because on paper, you may show providers that go to a specific location in your rural areas, but are they truly there 5 days a week? Or is it just a satellite clinic? Or is it just telemedicine, right? And so kind of pulling those pieces together in those rural areas and the expansion areas really comes together because not only you have to worry about data integrity, location integrity, you have to look at claims data to see if their cost and quality metrics are high because you're probably going to be stuck with them if there's not a lot of limited supply there, and kind of the overall facility and complex arching of the care there. So great point. And I think that really, you're going to find those challenges come to fruition when you come to the expansion areas.
Yeah. Yeah, I love what you're talking about in the rural areas. It's so true. Just think about the geographies, the different states, the community, market strategies, and there's pharmacy deserts that are out there. There's fitness deserts. There's food deserts, transportation deserts. What is the makeup of your membership? And when you truly think about it, what are you doing to solve for it? Based on not only your hospital systems, but the different provider groups that you have. And this gets back to that data accuracy. And to your point, right, they may say they're practicing at 20 locations, but in reality, they're not. Um, you know, Increasing, from an industry perspective, claims intelligence is just becoming more and more important year over year, just in terms of even the regulatory perspective. When you think about the organizations that are going through program audits or triennial reviews, or just really being able to understand and be able to decipher out, do you truly have a network that truly represents where your providers are practicing at, right? And are they truly serving the members, not only in the urban and suburban areas, but also in those rural, the SEAC areas where the providers and hospital systems are few and far between. So location confidence is critical, and understanding what that affiliated relationship is. So if a provider is supporting a rural location, are they contracted with a specific hospital system or a specific primary care that member has a relationship with, right? To again, avoid surprise billing, right? And truly keep that claims experience, that member care in network versus running into out of network type situations.
Josh, I'm going to put you on the spot just a little bit based on some of our prior conversations coming into this call. I always want to make sure we're giving tangible examples to our audience members that they can kind of internalize and think about. But you were talking about how you've been using affiliation insights, performance metrics, linking that all together. And you had mentioned earlier on the call about your internal dashboard and how that helps you evaluate the performance of your network. In fact, what you have said in the past, and I'm going to quote you on this because I thought it was very insightful, is that adequacy is how you build it, meaning the network, and then integrity is how you maintain it. And part of that maintenance, can you elaborate a little bit on your internal dashboard and how you're leveraging that today? What are some of the key things you're looking at? How often do you look at it? And what brought you to build it in the first place?
Yeah, once you build your network, your story is not over. Your work is not over, right? You kind of always have to go back and assess the health and the efficiency of your current network. And you'll only be able to do that if you have some sort of dashboard that looks at, number one, referral patterns, number two, integrity, right? If you do have a current, a adequate network, right? A pretty robust, adequate network, have you educated your providers to utilize that network enough, right? Or are they still sending referrals or patients to out-of-network facilities, out-of-network providers, and they are being caught with, to Bob's point, surprise billing, right? Because they trust in the provider that you put in the network to utilize the patient's network and your own network. So kind of that integrity piece is very, very key. And so we loop in claims data for our providers, right, to again assess cost and quality. We're looping in referral patterns. We're looking in how many times they are referring patients. We're looking at the HCC scores of the member population. And we're also keeping track of where our patients are utilizing the most care, what lines of service, what facilities. And we keep all this into internal dashboard, and then we kind of use this to find out whether or not providers are performing the way we want them to. Is there an educational opportunity? Or are there some bad apples in our network that we can replace with somebody else, right? And so kind of leveraging integrity data from an internal dashboard piece, using all of this data that we have. And if you don't, I mean, obviously there are publicly available resources to use to kind of paint that picture if you don't have internal dashboards already. But you really want to make sure that the network is functioning in the most efficient manner ever. And so conjunction using integrity dashboards, integrity data with affiliation insights really can kind of show you, are they truly performing? Are they kind of going behind your back and using a competitor? Are they, doing something that may or may not be, from a compliance standpoint, legal, right? Are they continuing to use a certain facility over and over and over, and why, even though they're not in your network, right? Is there some sort of issues going on there? So leveraging both is really how you really maintain that network efficiency and really keep abreast of the changes and the pivots and keep your network healthy.
I think as you talk about that, I want to start talking about trends, right? And I think having internal dashboard or automated systems that allow you to have that view seems to be a trend, right? Something that a lot of people are starting to embrace and lean into. What other trends are you seeing, Bob? I'll come to you first on this one, and then Josh, please chime in as well. I think you both have similar perspectives on this, but as far as trends that you're seeing and how those trends are going to begin to impact your strategic decisions especially as we're starting to look at moving into 26 and then beyond. Obviously, a lot of that strategy is 2-3 years out, right? So how are these trends going to be impacting those decisions over the next 3 to 5 years? I think we have an issue with Bob's audio at the moment. So Josh, do you want to pick that up first?
Yeah, I mean, some of the trends that I'm definitely seeing is the exploration and the entrance of a lot of private equity groups into the markets, right? That poses a risk with some health systems and some patients, because obviously private equity has a bad connotation, right? And so if they're sweeping up groups left and right and providers are joining super groups, you can't really determine whether or not they're going to continue to deliver true quality care, right? What is the motto? What is the message? Private equity did not take an oath to take care of patients, right? They're not doctors. So if they're just throwing money around and providers are kind of just taking that money to kind of group together, that is an issue, and that may be something that you want to steer away from when you look at affiliation insights and contracting. Kind of other trends that I'm seeing is, as Bob mentioned kind of earlier, site of service. Site of service is very, very important now, especially for those in VBC organizations. You want to have options that are not just inpatient and at a hospitals, right? For example, patients that just need an x-ray can pay $45 or $40 cash and get an x-ray at an independent testing facility, but they're going to be spending $200 or $100 at a inpatient hospital or a large system if they go in, right? So having options for your lines of service, so in this example, if you're a value-based care provider, having those options and bringing price transparency to consumers and to your members is really key moving forward, because everything's getting more expensive. Patients do not want to pay, more than $1 than they should, right? Insurance is getting expensive. So having site of service is going to be really important. Having price transparency is going to be really important. And you need to also, I think, moving forward, keep patients engaged, right? And so you need to create health plans or health programs to keep them engaged, to keep them coming back to deliver their annual wellness visits, keep them incentivized to maintain their proper care. Proper care at the end of the day will be more cost efficient to an organization than those patients that really don't have engagement with their care and only come in when things are serious or it's an emergency. So those are the trends that I see really popping up moving forward, and that people should be aware of.
Bob, I know you had some comments you wanted to make. Let's throw it back to you.
So, I mean, measurement is key when it comes to claims data, but I also like to think about the transparency of what do payer and payvider organizations have access to. When you think about the CAP surveys, HEDIS performance, star ratings, and what's ultimately going on in the market. How are the organizations being evaluated from a member's perspective? and really being able to utilize that back to your measurement and your monitoring strategy. When you're thinking about your provider profiles, you're thinking about your dashboards, your network integrity, being able to pull the nuggets out of that and really be able to look at that throughout the year. So as you really are adjusting your measuring strategy, your monitoring strategy to determine where are there areas of low-hanging fruit that you know you can pause, you can be able to make adjustments within your network, as well as how does that help to apply from an overarching annual strategy as well.
So now we talked about trends. We've talked a lot about the fact that Affiliation Insights helps you predict costs. We've talked about MLR, billing risks. There's so much that it impacts throughout the life cycle. We've talked about how it's trending, how this is becoming not something that you should be thinking about maybe later, but you probably should be thinking about it right now. So Josh, what advice do you have for someone who maybe isn't doing this today or is starting to think about it or looking at it? What advice would you give them today as far as how to get started or what they should be thinking about?
Yeah, great question. It's never too late to start, right? So if you're not thinking about your network in a data-centric way, it's definitely high time to. The future of building networks, the future of care is going to be delivered primarily based off of the data that you have or the data that you can use to model your future. Again, medicine is getting more and more complex as we go on, right? There's introductions of new care patterns, telemedicine, new rules and regulations every single day. And so all of these will have an effect on how you build your network, how you maintain your network, and how you prolong your network. So I would definitely try to invest, if not, or try to acquire some sort of data analysis tools, partner with people that have data that is available, and kind of use that in conjunction with talking to your own providers, right? I think the best thing to do to kind of gauge and start somewhere is to talk to your providers, ask them about their patterns of care. Who are they referring to? Why are they referring to them? What do patients tell them, right? What do patients tell them about these facilities, these doctors? What are the complaints? And so kind of starting from the physician side, asking them about, the real life scenarios, asking about the complaints, really getting into looking at, patient issues or patient satisfaction scores, using that as a starting point and then adding data to then again build your network or maintain your network or prolong your network will be something that I would definitely recommend everyone to start doing. Again, we want to model everything off of real world, case scenarios. And so, having Affiliation Insights is fantastic because we've never had that access before to kind of pivot, and have that insight. But, starting from kind of the bottom with your providers and building on top of that layer by layer until you're in a comfortable place to now contract and build would be something that I recommend.
Bob, I'm going to ask you the same question. Josh, I think you covered a lot there. I think, it's kind of don't walk, run and start, really pulling those data sources together and layering them to really give you a strategic view. Bob, what have you been seeing best practices or advice that you would offer to our audience today?
The transparency is key. I 100% agree with Josh of working with your providers, your provider groups, and understanding, where they're practicing, who are they servicing, but truly thinking about and utilizing claims intelligence is also key. And really, as you're thinking about, which provider groups that you actually want to contract with, where's the bulk of their claims going to? They might have affiliated relationships with 30 institutional affiliations and 15 outpatient centers, but truly where are they really referring members to? What do those admitting privileges look like? And the devil's in the detail, right, when it comes to claims, and that's going to help to support things like affiliation strength, and it's going to help you to know what are the most appropriate provider contracting groups that you want to have that solid contracting relationship with. You really want to focus in on transparency around cost, quality, to truly help magnify and focus in on things like total cost of care. So definitely utilizing claims experience. Transparency is key, having those open conversations, but continuing to focus in on measurement and understanding your landscape as things continue to change, especially within the healthcare industry across your lines of business.
I really enjoyed this conversation. I hope you did too. There are some key things that I took away from this. It really is important that we start becoming data rich, really leveraging the insights that we have. You heard Josh talk about how they have an internal dashboard that allows them to really see into their performance metrics, including cost, quality, and really importantly, those affiliation insights. That internal dashboard has been instrumental in allowing them to really improve their network design and their network strategy. They talked about how you need actionable insights around provider and facility affiliations because unclear relationships really add to member dissatisfaction. And in fact, Joshua talked about how you want to build your networks in a way that reflects real world care delivery and how important that is to member satisfaction. So it's not just about closing gaps, it's about closing gaps with the right providers. So the key to all of this that I took away is you need to start now. This is something that can't wait. You got to start looking at these metrics. You really got to, go from being information rich to data richer. I hope you enjoyed today's podcast. I really enjoyed being part of the conversation. We know you have a lot of podcasts to choose from. We're glad you chose to spend time with us today. Please take a moment to give us some feedback. We really take that into account. It helps us improve the Totally Adequate podcast over time. Thank you for tuning in. Thank you to our producers, Sophia Timmermeyer, and we'll see you next time.
Thank you for tuning in to this episode of the Totally Adequate podcast. If you enjoyed it, we'd appreciate it if you could rate us on Spotify or leave a review on your preferred podcast platform. Your feedback helps us grow and bring you even better content. We also invite you to send us any comments or topic ideas by emailing us at thetotallyadequatepodcast@questanalytics.com. The Totally Adequate podcast is produced by Fowler House Films and Quest Analytics. Thank you for listening.